Hello and welcome to Dragon Bites, the paediatric podcast aimed at paediatric trainees or anyone interested in child health. I'm Asim, one of the presenters for Dragon Bites and one of the paediatric trainees here in Wales. This week we're going to carry on with our current cardiology series on left to right shunts with Professor Orhan Uzun. He's going to talk to us today about atrial septal defects. Anyway, let's get started.
So second, let's move to the lower end.
Yes, please.
Towards the heart. So we're coming towards the heart. So you can see left to right shunt. We started from its origin. So we'll build up our foundations. If you don't build your foundation like that, you will forget things.
Yeah.
Now we're going to move to the heart itself. Let's start with the venous return coming to the right heart. Yeah. So venous return coming outside the heart, which already discussed, arteriovenous malformation. Now we're going to look at the venous return already inside the heart, but they move to the right side from the left side at atrial level. So intra-atrial shunts. Common one, atrial septal defect.
Right, so let's start with atrial septal defects. So from what I remember, there are actually quite a few categories of atrial septal defects, aren't there? So there's, ASD secundum, is it primum, the
Correct.
first one? And then would you also possibly categorize a PFO as an atrial septal defect?
PFO, it becomes abnormal beyond 3 months of life if it fails to close. When it doesn't close, then it can be called either persistent foramen ovale, or it can be called small ASD, or can be a genuine important atrial septal defect. But how we describe atrial septal defects, there are 4-5 forms. You told me only 2 of them.
Yeah.
You said primum and secundum. Do you think there is also tertiary or tertium?
I'd hope so.
Well, there is a third form of it, but we don't call it, of course, tertium, or I don't know what it is called.
It's not going to be, so it's not tertium and quaternum or something like that.
What we call it at the top end of the atrial septum. So if you think about atrial septum from the junction of atrioventricular valves, mitral and tricuspid valves, if the lower portion of the atrial septum is missing, we call that primum atrial septal defect.
Sure.
If the middle portion, where the fossa ovale is expected, is missing, we call that secundum atrial septal defect. Secundum. In secundum atrial septal defect, you need to remember there is an edge at the bottom, and there is also an edge above. So the foramen ovale or secundum ASD occurs between the 2 edges of the atrial septum, right in the middle. And the third portion of the atrial septum, top portion, where the superior vena cava and pulmonary veins enter. And if that section is missing, we call that sinus venous ASD. Have you heard of that?
No, I haven't heard of that.
Okay, that's called sinus venous. It's very rare, exceedingly rare. It's not uncommon to be overlooked and missed. And those sinus venous ASDs usually detected later in life, sometimes as late as teenage years, because they don't come into medical attention so easily. And also it's difficult to detect with ultrasound. So sometimes sinus venosus ASD can also exist where the inferior vena cava enters to the right atrium.
Right.
So you either consider as the fourth one, or within sinus venosus you separate them into 2.
Okay.
So superior sinus venosus, inferior sinus venosus.
Right.
So inferior, close to inferior vena cava, the superior one, close to superior vena cava. The only differentiating point between the 2, if it is the usual sinus venosus ASD, close to superior vena cava, it is associated by default partial anomalous pulmonary venous return of one of the right pulmonary veins drain into superior vena cava. But in the inferior vena cava type sinus venous ASD, there is no such pathology.
Okay.
So that's the differentiating point. There is a 4th type atrial septal defect, perhaps. You may or may not call it atrial septal defect, but it's the coronary sinus defect, or what is it called, fenestrated, unroofed coronary sinus. Coronary sinus is a structure, collects coronary flow and brings it to the right atrium. And it opens like a little tube just above the tricuspid valve, 1 to 2 millimeter orifice. But this is also an extra cardiac structure. It comes outside of the heart, behind the left atrium, inserts into the right atrium, and drains into the right atrium. If the wall between the coronary sinus and the left atrium is deficient, either continuously or with little fenestrations, this is called unroofed or fenestrated coronary sinus.
Wow.
So unroofed coronary sinus also can cause atrial shunt.
Those last two, I've never heard of them. That's really interesting.
I think we've seen last 20 years since I've been here, unroofed coronary sinus in 3 or 4 cases. Extremely rare. An inferior vena cava type I have never seen. So you can imagine how rare it is. Sinus venous Asd I've seen about half a dozen. That's also not very common. Most common one is no doubt is the secundum ASD, and the second common one is primum ASD in isolation. But if you take primum ASD in the context of AV septal defect, that is more common than secundum ASD, but less common than foramen ovale.
Okay.
And the right to left shunt can also occur with other pathologies, such as coronary artery fistula, because coronary arteries sometimes may drain instead of into coronary sinus. They might have large opening into the right atrium.
Right.
That also causes left to right shunt. So you need to be careful. If there is no defect in the primum septum, secundum septum, or sinus venosus septum, or in the inferior vena cava section, then you're going to look at either coronary sinus, or you're going to look at additional flow into right atrium, coming from pulmonary veins. Could be abnormal pulmonary venous return. Could be coronary artery fistula. Could be an additional vein coming into the right atrium or left atrium. So those are the extremely rare ones.
Wow. Okay.
So what is interesting to you, more relevant to you? Primum ASD, secundum ASD, sinus venous ASD. That's what you need to remember. One of the questions was PFO and small ASD. People get confused how we can discriminate the two. Do you know what percentage of children and adults have probe patent foramen ovale without causing any problem?
I feel like, from what I can recall, I think the percentage is actually quite high. Was it something like 20%?
Absolutely. Spot on. You impressed me so much this morning. 1 in 5.
1 in 5.
1 in 5. 1 in 5 adults and children would have probe patent foramen ovale. And foramen ovale can vary from a millimeter to up to 4.9 millimeters. So less than 5 millimeters, we call it foramen ovale if it does not cause 2 things: heart enlargement, second, murmur. If it is more than 5 millimeter, then between 5 millimeter and 1 centimeter, we call it small ASD. Small ASD. And how we decided whether it is significant or not, if the communication, secundum ASD, is causing right heart dilatation, ECG changes, and also auscultation changes, along with murmur, then you call it significant. If the ASD is over 1 centimeter, usually they require treatment. Small ones also might require treatment, depends on, of course, whether the amount of shunt is quite significant or not. Sometimes ASDs may require treatment early on, sometime later on. We'll elaborate on that later in the discussion.
How would any of these ASDs typically present?
Do you expect these patients yourself? Let me just direct that question to you. Do you expect them to present with florid heart failure?
No, I don't. I wouldn't expect so because
Spot on.
yeah, from what I understand, most ASDs just tend to be incidental findings without any significant cardiac impact anyway. And then I don't think I've ever come across a case of ASD associated with heart failure, but of course my experience with this is relatively minimal.
You're absolutely right. Exceptional cases, I must say, the patients who presented early on tend to have additional problems, prematurity, or lung pathology, or elevated pre-existing pulmonary disease, elevated pulmonary artery pressure, pulmonary vascular disease, or else. And those patients tend to have sometimes heart failure, but it's exceedingly rare, and the majority of these patients would remain asymptomatic. In fact, we leave them alone until they reach 4 or 5 years of age, and then we do treat them when they're a bit older. Either we'll discuss all those things, but you're right. Symptoms are completely incidental, relies on incidental findings, and those findings may come about when you listen to a patient's heart. When you palpate the pulses, these patients don't have high volume peripheral pulses unless they develop left-sided failure for exceptional reasons. On examination, when you palpate the chest, you would feel the right ventricle being a bit dominant because right ventricle would dilate and pulmonary flow would be increased, and auscultation probably would give you the most reliable suspicion. And what could that be, you reckon?
What would
Systolic murmur coming from atrial septal defect?
No.
Absolutely no. Yes. One thing I would dread to hear from you, yes, atrial septal defect causes murmur as the blood flows through the atrium. No, because a murmur to be generated, you must have good amount of pressure drop between the two chambers. What is the pressure in the left atrium? 6, 7, 8 maximum in a child.
Yeah.
What is the pressure in the right atrium?
I'm assuming something very similar.
4, 5,
Yeah.
6. So only 1 to 2 millimeter or 3 millimeter mercury of pressure drop.
Yeah.
So human ears cannot hear that unless we've got bat ears and incredible sensitivity. So the murmur arising from secundum ASD is not due to the shunt across the atrial septum. What it is due to that?
Oh, that is a good question. I really don't know.
You do? Follow the sequence. Blood goes through the
So
tricuspid valve, but the murmur would come after the tricuspid valve as the blood goes through the semilunar valve of pulmonary artery.
Okay.
So because pulmonary artery has a valve, and as the blood flows through the pulmonary valve in normal circulation, does not cause any turbulence or resistance or vibrations. But if you are pushing 1.5 times or twice the size of volume through the same size orifice, you would have more resistance, more turbulence, more vibrations across the valve. So the murmur in ASD is due to increased flow across the pulmonary valve.
Wow.
Okay.
If you hadn't explained it to me, I would never have guessed that would be the case.
But you knew that it was not coming from the atrial septum.
Yeah.
But you didn't know what it was due to.
Interesting.
And do you expect any other additional sound in addition to what we call the murmur, flow murmur, and it is diamond shaped, crescendo, decrescendo, or systolic ejection murmur quality? Do you hear any additional sound?
Would you hear a split second heart sound then?
Wonderful. The second heart sound remains split. Aortic closure and pulmonary closure remain widely split from each other. So splitting of the second heart sound is the hallmark of this condition.
Wow. Okay. Yeah. Very well explained.
Well, what we call it fixed splitting of the second heart sound.
Fixed splitting of the second heart sound.
Wonderful, wonderful. If patient developed pulmonary hypertension, then second heart sound might be louder.
Okay.
And that's the only thing. If there is no pulmonary hypertension, then you wouldn't expect second heart sound
to
be loud. Okay, that's excellent, brilliant. I hope the audience will take this message and will keep it forever.
Yeah.
One of the things to take forever. And to take on.
Excellent.
Now we're going to move on to perhaps investigations. What would you do? So start with ABC. ABC is, as you know, in cardiology, in cardiac patients, chest X-ray, ECG. That's what you can do. An echocardiogram, a pediatrician, this is our aspiration in the future.
Yeah.
To do three things: to look at the function, to look at the size of chambers, to exclude effusion. Three things you can do. Call cardiologist, but before you call, you need to look at the chest X-ray. Can you tell me one thing? Then I will perhaps add two more things.
Okay. So I suppose would we be expecting some sort of right atrial enlargement?
Perfect. It shouldn't be more than two
fingers. Depending on how big your fingers are.
But certainly no more than 2 fingers. If it is more than 1 finger, be suspicious. And what else? Now it is my turn. The pulmonary conus above the atrial appendage would be bulging into the left lung field. So you look at the pulmonary conus, and pulmonary artery would be large. That's the second finding you will see in the left to right shunt at atrial level. And you would not see plethora in these patients, like in VSD cases or PDA cases. Heart would be enlarged, but mainly the right heart. If it is volume loading, it is not hypertrophy, it's not pressure loaded heart, therefore the apex would not be upturned, like we see in tetralogy of Fowler.
Yeah.
So just heart would be enlarged to the right at the atrial level and the lateral wall of the ventricle. But the apex would be staying in the same spot. And occasionally in these patients, you might have X-ray findings relating to additional pathologies other than secundum ASD, and if that is due to coronary pathology, or you can have secundum ASD with TAPVD, you can have secundum ASD with other lesions like tetralogy of Fowler, coarctation, aortic stenosis. So additional lesion might give you confusing findings of plethora, confusing findings of fluid in the fissure, but solely ASD would just give you little dilated heart and dilated pulmonary conus.
Okay.
So 2 things in that. But always, what I said, do not ignore the other things. Just look at the look at everywhere.
Sure.
So once you find large heart, don't say that's it. I found the supportive finding. Look at the ribs, look at the lung fields, and look at everywhere.
Okay.
Then you move to ECG.
Yeah, again, would this just show sort of like right-sided enlargement again?
Excellent, yes. What are the signs of right-sided enlargement? Let's go through. First, P waves become peaked. Yeah. So peaked P waves on the ECG. In terms of width, it should be more than 2 small square. In terms of height, it would be in children more than 2.5 small square.
Okay.
In infants, perhaps 2. In bigger children, 2.5. In adults, more than 3. It's called right atrial enlargement. So peaked. Okay. And the second finding would be related to transit time of sinus impulse, PR interval. Would you agree?
Yeah, because that would be because you got a larger right atrium, so the transit time would be longer, wouldn't it, for the signal to travel across the atrium?
Because sinus signal travels through the atrium from muscle to muscle connection. We call that syncytial pattern. Syncytial pattern. So there isn't a cable or bundle branches like in the ventricle. So that's the differentiating point between atrium and ventricle. So PR interval prolongation is a reflection of enlarged right atrium, remember. The part of it is in the AV node, remember. PR interval is not just the transit from sinus node to ventricle, but also through the AV node. And we need to remember that. How about the QRS duration?
If we're looking at the QRS, so that would be how the ventricles the signals across the ventricle. So I suppose, would it depend upon whether the right ventricle at this stage has been affected? So if we've got right ventricular enlargement, we might get a wider QRS complex at this stage?
Yeah. And would you call this true right bundle branch block? Is there a damage to the right bundle?
I don't think so, no.
What it is due to then?
It's because of the enlargement of the right ventricle.
Exact scenario. And in those patients, in fact, after closure of ASD, right bundle branch block disappear most of the time.
Oh, right there, yeah.
And in some cases, it might take a longer period of time for the right bundle branch block to disappear. But we call it right bundle branch block pattern. RSR pattern, right bundle branch block pattern, but it does not reflect true right bundle branch block. And the QRS duration is not as long as in true right bundle branch block patients. Right. Yeah?
So what would we be thinking of in terms of QRS duration?
Now the QRS duration should be less than 85 milliseconds in children. Okay? Remember, in infants and the children. Anything over 85 is abnormal. So in these children, it's definitely less than, majority of the time, ASD in small children, less than 90 milliseconds. So you would, in an infant, QRS duration is about 60 milliseconds, no more than that. And bigger children, 70, 75. If anything is over 80, between 80 and 90, we should be suspicious.
Right.
Also, if the QRS is fragmented, so you have RSR pattern in V1, that should be highly suspicious. And the third thing you need to look at the QRS is called crochet in French, or croquetage finding.
Right.
I don't think you.
It definitely isn't ringing a bell.
By the look of you.
No, not at all.
So this is new thing that cardiologists hide to ourselves, but I don't hide anything. I'll pass it to you. You look at the inferior leads. Lead 3 and AVF are the inferior leads. So when you look at those, if you see notch on the QRS complex, so if patient doesn't have RSR pattern, and QRS complex is not dilated, so they are not 80 milliseconds, they are not 85 milliseconds, it's not abnormally dilated, but it's not upper end of normal.
Yeah.
Then you look at the inferior leads. If they are notched, tip of it notched, and it's called croquetage.
Yeah.
Or crochet finding.
And it
supports the supports the atrial septal defect.
Wow.
So that's an experimental study. It's been published, and I think you should remember that. And it will make you look very smart. If you tell the cardiologist that the R waves are notched in lead 3 and AVF,
they'll be impressed.
And there is split-second heart sound. Yeah. Everybody, even yourself, would be impressed with this. So that's the ECG finding. How about the T waves and ST segment? Because we go in sequence, segmental and sequential analysis. T waves would be altered, or ST segment?
I'm not entirely sure they would be.
T waves, remember, ST segment T waves are very sensitive to volume loading, pressure loading, and ischemia.
Okay.
So hence they would be affected. So volume loading of the heart can give itself as deeply inverted T waves, or peak T waves, depending on the age.
Right.
Depending on the lead you're looking at. So you need to look at if the P waves are peaked, too deep, or too peaked, then you must be suspicious of that. Large, prominent T waves, or slight ST segment sagging, not horizontal, but rather perhaps smooth and circular. And would that suggest some volume loading with deep T waves?
And would that be more prominent in certain leads than others?
Right-sided leads mainly, of course, in children, because we know those ones are negative, must be negative in children beyond first week. If the negative T waves become prominent, deep, quite obvious, and ST segment virtually disappears, just merges with the T waves, then it indicates volume loading is quite significant. If the T waves are not negative and positive in children, say between 1 and 3 years of age, in V1, V2, V3, and there is an ASD, what would you be concerned of? So you would think of significant RVH as well as volume loading.
So pulmonary hypertension?
Excellent. So right ventricular hypertrophy and pulmonary hypertension should be excluded in those patients and should be one of the concern that we should exclude. Excellent, excellent, brilliant. So we did the ECG analysis. Then we will go on to the echocardiogram. Echocardiogram will show the position of the ASD, and according to the position we'll decide whether it is primum, secundum or sinus venous ASD or inferior sinus venosus, or this is something else, rare entity. Once the diagnosis is established, we will decide how to treat this and how to manage this child. First of all, it would be exceptional for ASDs to present acutely, and therefore you must look for reasons. Anemia, arteriovenous malformations, vein of Galen. You need to look at all those things. You need to look at unroofed coronary sinus. And you need to look at TAPVD with obstructions. So all these must be excluded. Or patient might have cystic fibrosis or lung pathology, and additional volume may not be good for these patients, and those patients require earlier treatment, either device or surgical closure. Initially you can put them on diuretics, but right-sided heart failure, you mustn't reduce the volume too much. You must be careful. So the judicious use once a day, 0.5 milligram per kilogram furosemide and spironolactone orally once or twice a day, and follow the patient. And try to grow patient up to 18 kilogram if possible. If patient is over 18 kilogram, you can do device closure. Some individuals may attempt in smaller children, but the manufacturer does not recommend, unless any product appears and it's not metal. It can be used in even small children with small caliber tubes passed through the veins. Then perhaps we can do that in younger children, but we do tend to wait until they hit 18 kilogram to close it interventionally. Or you can do surgery, of course, surgical closure. Some centers attempt it through thoracoscopy, but in Britain none of the centers doing it. Just as an information I'm giving to you, if you read and come across, it's known, and that is the way to go in the future. It will happen, and I'm going to work on it.
Okay.
And I'd like to see you guys working on it. That's the point of teaching you. So please concentrate on the management of ASD.
So we got device closure would be the mainstay of management by the sounds of it. So long as we're at a good weight.
You hope. If the size of ASD and the position of ASD is suitable, we do not attempt device closure in sinus venous ASD in Britain as yet, but there are reports elsewhere in the world sinus venous ASD is also attempted. But the device closure generally is used for secundum ASD with good edges and rims on either side of the defect to anchor the device and sandwich the hole between the two sections, two wings. Sinus venosus ASD, as I said, surgery, because it also requires redirection of pulmonary vein. And primum ASD definitely requires surgery because you need to repair the inlet valves too. So only secundum ASD is amenable to device closure as it currently stands in this country, but in the future this may change, and surgery involves lateral thoracotomy in these patients, sometimes frontal, and depends on the surgeon. Some people attempt lateral in female individuals, but majority of the time it goes from the front. And you do patch closure, either use pericardial patch or dacron patch to repair these ASDs. In the secundum section, in the sinus venosus section, you need to redirect the pulmonary vein to the left atrium, as well as closing the ASD. In the prime ASD section, you close the prime ASD, but also repair the inlet valves, because prime ASD over 90% of the time associated with a cleft in the mitral valve. Cleft means the anterior mitral valve has a gap
Yeah.
in the middle, somewhere in the middle. So that needs repairing. As far as the surgery is concerned, as I said to you, it's done under bypass. And in the future, as I mentioned to you, thoracoscopic procedures are being tried, tested in other centers, but it's not being used in the UK. And hopefully you guys, new generation, will accomplish that. I don't see any reason why it shouldn't be. So I hope we summarized atrial septal defects in terms of treatment, but this is the acute and chronic treatment. But when do we do it? I mentioned about the intervention, 18 months, 18 kilograms, rather. The surgery, we do tend to wait until they reach 4 years of age, or about 14, 15 kilogram. The reason we do it before school age, not because we're worried, but they do forget.
Right.
And it doesn't become traumatic. But if they reach sort of 10 years, 12 years of age, it becomes traumatic and remember that experience. Some people deliberately delay it. They don't want to have operation. So we may delay up until 12. If the ASD surgical closure in significant cases delayed beyond 12, 14 years of age, then the changes in the right atrial size and ventricle and on ECG become irreversible. Danger of delaying it beyond, in fact, 14, 15 are 1, congestive heart failure, 2, dilated heart, therefore poorly contracting ventricle, 3, arrhythmias. In fact, those patients who were not picked in childhood or were not treated in childhood and detected in adulthood in 30s or 20s, they come with congestive heart failure and atrial fibrillation, arrhythmias. So maybe arrhythmia, first sign, or maybe congestive heart failure, or maybe just exercise intolerance in their 30s and 40s. So anything else for us to summarize, perhaps 3 things to have? Well, what I would like you to remember, to say, never say the murmur you hear in ASD is due to atrial septal defect, flow across the atrial septal defect. You will not forget that in the rest of your life.
Sure.
Okay, that's the one thing. And the second thing I'd like you to remember, the secundum ASD or shunts in atrial level does not cause naturally congestive heart failure in young age, in childhood. Such thing happens later in life, or such thing happens outside the secundum ASD with additional lesions. That's what you need to remember. And they need to be treated in childhood if they are big enough and causing heart dilatation, and beyond, if you delay it beyond 14 years, the changes become obvious, and they should be treated around 4 or 5 years of age to prevent long-lasting after effect and side effects on the psychology and development of the child.
Excellent. Right, thank you again, Professor Uzun. That's been an excellent seminar on ASD.
We put our hearts and minds into this, and I hope that the listeners will enjoy. And we would appreciate the feedback, won't we? And if they would like to add something we've missed, we would like to hear from them so we can put more emphasis on those.
Yeah, absolutely.
And I hope they will enjoy it.
Me too.
And we would like to tell them that the next talk on left to right shunts will be about VSD's intraventricular shunt, PDA and AP window. And it will be even more catchy,
more exciting,
with more jokes in it.
Excellent. Right, thank you very much, Professor.
You're welcome. Have a good rest.
And I just wanted to say thank you again to Professor Orhan Uzun. As he mentioned at the end of that podcast, join us again next week for an episode on ventricular septal defects. That's all for this week. Thank you for listening to Dragon Bites.